sorry for that. Now you're able to hear me now?
Yes, you're audible, sir. Your
Ah,
presentation is also well seen. Please start.
okay,
Thank
so
you.
this unusual coronary abnormalities presented. Good afternoon, everyone. Detected on echo, and then we did the management after that. All dysfunction are not DCM as a pediatric cardio. We are honest to diagnose any DCM to rule out any treatable cause. This is an 18-month-old diagnosis DCM presented with multiple times of failure and on multiple medications, and again presented with failure in some pediatric unit and with having the features. And then this is the X-ray that shows cardiomegaly and LV venous congestion. So this, when we did ECG, we find out this time there is a deep Q waves in the one and AV. So we thought some coronary issue which was missed before. So we again want to see that, and we have to rule out whether anything coronary which is the cause for that. So this is the DCM that shows the EF of only 22% dilated LV. But when we did the echo, we found out there is a aliasing at very high scale at the coronary origin. So we suspected there must be, because of the Q where there is a suspected LMC turbulence. So we thought there may be congenital LMC origin stenosis on echo itself. So we thought we'll confirm that. When we did the cath, the LV-ADP was 25, and when we did the coronary angiogram, you can see that this is a congenital hypoplastic LMC stenosis. So with the selective injection also, we proved that it's a severe congenital which we detected on echo. And so the clue here was the high scale mosaic and the aliasing pattern of the coronary seen during, which was missed during initial evaluation. Everyone thought it's a normal origin. So we underwent successful surgical correction, 3 years old follow-up, it's a normal. Case 2, never ignored unusual findings, 6-month-old referred for cardiac evaluation, asymptomatic otherwise, with PSM, chest clear, no edit sound. Just routine evaluation, we found moderate VSD. But when we see the coronaries, you can see there's an unusual pattern. Normal pattern is the Y connection, what I showed up, and there is a rounding of the vessels. And then we thought there is something abnormal with the coronary, which we are unable to detect. And there is some PA reversible flow in the. So we thought we do the cardiac catheterization, prove it, which proves the QPQs of 1.7, LPDP of 11. And this is the injection. You can see this is the. It looks like over the from the very overview, it looks like normal, but if you see there is a cutoff of LAD from the main LMC. So this is the origin LAD atresia, so which we detected, suspected on echo, and then we found out he will do the cardiac catheterization to prove it. And this is the LO caudal view to show, and this is the selective with 3J catheter to show that. And this is the proximal LAD atresia, late LAD filling, and some collateral which is causing the PA filling. And this is the correlation of the echo as well as the angio correlation which proved. Because the patient is asymptomatic, detected 1 month back, so we thought as the patient grow, we discuss with surgeon. In the next follow-up, we'll try to do the surgery with the PSD. It's already moderate, so no need to do anything. So here the clue was unusual branching pattern, diastolic flow in pulmonary artery. So management, we are still on the follow-up. We try to do in the next sitting. So adjust your scale. This is the 6-year-old just discomfort with dyspnea evaluated outside. Small coronary fistula, good LV function. And you can see the LMC origin is very much normal. There is a diastolic flow in the PA. But as you do the decrease the aliasing and decrease the scale, we feel a lot of collateral in the LAD territory. So with the normal LMCA flow, collateral LAD is something with the LAD, although the LMCA was normal. So we did the angiogram and the catheter. You can see it's a just the RCA which is very dilated, and once you see the RCA injection, that is the only the LAD is abnormally coming from the PA. So this is the diagnosis of the alert pa. She is posted for the surgery next week because this just last week only it got diagnosed. So this is the injection. So here the clue, in spite of normal origin, you have to do the scales, and why you see there is a small collateral in PA, which is initially diagnosed PA fistula is small, but it turned out to be the alert pa, which is also rare anomaly. Case 4, beware of fix. This is one of the very interesting case of 5-year-old underwent the pulmonary root translocation with no ECG Q wave pattern in the beginning. And when the post-operative stomach was with a small residual VAD, multiple episodes of failure as well as the pulmonary edema. And when there is a flash pulmonary, every time when we are extubating, she underwent resuscitation. But one of the very common findings, the EF is fixed. Even if you do inotrope, even she arrested, the EF remained fixed at 30% only. And when we did on the 15th day, we found that the Q waves are appearing. So we did the angiogram. We found out there's a congenital hypoplastic LMCA, which was not seen during evaluation. And then we see the RCA. It's the retrograde filling through the collateral, and that collateral was not enough to sustain the left ventricle. That's why she is going into multiple pulmonary venous congestion and the pulmonary edema. So unfortunately, we thought we discussed with surgeon, but the next day she developed the VT and we not able to resuscitate. So the clue here is fixed LVF even after inotropic, even after resuscitation, with appearance of Q waves in ECG over the period, not immediately, but after 15 days because of inadequate collateral. So, in short, the clues for Code we already know: LV dysfunction. These are onus on the pediatrician. All dysfunctions, all DCM are not DCM2. The onus is on the pediatrician as well as the cardiologist to rule out the treatable cause. Mosaic turbulence are arising on high scale. Fixed EF, pre or post surgical, unexplained MR, collateral flow on echo, dilated RC, echogenic LV endocardium, abnormal branching pattern which we found in this, and diastolic flow in PA. So these are some various clues which add on to the list of the suspected coronary abnormalities what we know to that. So with that, only with the echo we are able to diagnose all these things, and we confirm our diagnosis over the period with the angiogram as well as with the thing. So thank you. I'm open for the question. Thanks a lot.
Over to the judges.
Yeah, Dr. Verma, nice cases you had shown, and good